Hi there, my name is Ashley Dowdy, and I'm a physician assistant at the West Cancer Center in Memphis, Tennessee. Today, we'll be talking about surgical therapy for breast cancer. So first, we'll start with just diagnosing breast cancer as well as staging of breast cancer, and then move on to the surgical options for everything from early breast cancer through locally advanced, inflammatory, as well as metastatic breast cancer. So when we're talking about diagnosing breast cancer, certainly patients will come in with palpable masses that'll be worked up. But with the advancements in screening technology, many breast cancers are found on imaging alone rather than palpable masses. So when an imaging abnormality is discovered, whether it's a mammographic abnormality or ultrasound abnormality, a core needle biopsy is recommended for diagnosis. Surgical biopsies are not used for the diagnosis of breast cancer, but core needle biopsy is standard of care. So for an ultrasound abnormality, ultrasound guided biopsy is recommended. This is a fairly easy procedure for patients to tolerate. They're able to lie on their back. Ultrasound is used to find the abnormal mass or abnormality, and then the skin is cleaned, numbed, and a larger hollow needle is able to go in, take pieces of the mass out. Very importantly, once the samples are obtained, a biopsy marking clip is left in place. So this is a titanium marking clip. It's about the size of the head of a pin, so very, very small. Patients really wouldn't even know we were doing it if we didn't tell them, but really important so that we kind of know where we've been and what we've sampled, and kind of used as X marks the spot. For a mammographic abnormality, such as calcifications, the core biopsy for that is stereotactic biopsy. The positioning is a little bit tougher on patients. There's a special stereotactic table where they lay on their belly. There's a hole in the table and the breast hangs down through the hole and is placed into mammogram compression. Once the abnormality is found on the mammogram, then the rest of the procedure is the same. The breast is cleaned, numbed, larger hollow needles able to go in and core pieces of the abnormality out. With a stereotactic biopsy, the specimen is then typically x-rayed for a specimen radiograph to ensure that some of the abnormality that was seen on mammogram is now in the specimen. And again, a biopsy marking clip, very important that that's placed in the area so that we know where we've been and what we've sampled. Once we do get a diagnosis of breast cancer, typically patients have already had a mammogram and ultrasound, but breast MRI is something that can be used. It's not mandatory in every new breast cancer diagnosis, but certainly can be helpful for the appropriate patient in determining the true extent of disease. So once we have our diagnosis, staging is important to help determine treatment. The standard staging for breast cancer was the TNM criteria, so tumor size, nodal involvement, and any metastatic disease. But the new staging guidelines actually also include biomarker information, like the grade of the tumor, the receptor status, ER/PR, and HER2, and even sometimes oncotype results come into play. So again, this is just kind of a sample here of the anatomic staging, TNM based only. Really, this is not used anymore unless someone does not have access to the biomarkers. So on the right here, much more expansive table showing the new staging guidelines and recommendations. And this includes the biomarker information and based on imaging, physical exam findings, and the details of the biopsy results. So a lot of times once we have a new patient diagnosed with breast cancer, they'll say, well, do I need a full body scan? And the most up-to-date NCCN guidelines state that imaging for distant disease is not required unless someone has clinical signs or symptoms to suggest distant disease. So perhaps a bone scan would be performed for bone pain, or CT of the chest for significant shortness of breath or pulmonary symptoms, CT of the abdomen for an abdominal mass or pain, but just getting imaging to stage for distant disease is not required. So when we're talking about treatment for early stage breast cancer, this is referring to stage 0 breast cancer, which is DCIS or ductal carcinoma in situ, the earliest form of breast cancer that does not have the ability to spread outside of the breast, as well as invasive carcinomas that are either stage 1 or stage 2. Treating breast cancer is a very multidisciplinary approach, but in these early breast cancers, surgery is often the first step in treatment because the results can tell the other rest of the team kind of what the adjuvant recommendations should be. So when we're counseling and talking to patients about surgical options for breast cancer, we kind of have two choices. We either remove the breast or we save the breast. So removing the breast is a mastectomy. Saving the breast is a lumpectomy, also called a partial mastectomy. In terms of breast conservation for breast cancer, this typically includes the surgery, lumpectomy, as well as radiation therapy. So when we're talking about these choices with patients, I'll always start out by saying, we do try to save the breast whenever possible. And the reason for that is that there's never been any data to show that there's any survival advantage to removing the breast. So simply put, we don't save anyone's life by taking their breast off. Based on the NSABP B06, survival is equivalent between mastectomy and radiation therapy with a lumpectomy. Now, there is a slight difference in the local recurrence risk. So following a lumpectomy and radiation, there's approximately 5% risk of local recurrence. But following a mastectomy, there's a 2% risk of local recurrence. So patients are often really surprised by the fact that neither of those numbers are zero. So again, whether it's mastectomy or lumpectomy, very small risk of local recurrence, anywhere from 2 to 5%, and survival is the same. So then the next question a lot of times is, okay, well, if there's no survival advantage, why did my Aunt Sally or my friend Sue, why did they have a mastectomy? So there are still certainly times when a mastectomy is indicated. That would be if there's multicentric disease, so multiple tumors in multiple quadrants of the breast. If the tumor size is too large compared to maybe a smaller breast and removing the tumor would leave a significant cosmetic defect, we might opt for mastectomy in that case. If the tumor is centrally located and we have to remove the nipple-areolar complex, many times we would just do a mastectomy in that setting. Or, again, lumpectomy comes along with radiation. So for a patient who's already had radiation or has any contraindication to radiation, then mastectomy might be a better option. And then some patients, even though we recommend lumpectomy or counsel, some patients just opt for mastectomy. So other things to consider when making decisions about which type of surgery a patient will have, genetic and family history. So a patient with a genetic mutation may opt for mastectomy even if they have a small tumor. Radiation therapy, again, is important as that's part of breast conservation. So in general, whole breast radiation or partial breast radiation will be used adjuvantly following a lumpectomy. There is an exception to that. So CALGB 9343 showed that women over the age of 70 who have hormone receptor positive tumors and will be on endocrine therapy and tumors that are less than 3 centimeters, they can omit radiation as there is no survival advantage in that setting. In terms of radiation following a mastectomy, in early breast cancer, radiation is usually not required following a mastectomy, but occasionally following mastectomy radiation might be indicated, and that would be if the tumor is larger than 5 centimeters, if there ends up being skin or chest wall involvement, if there are positive surgical margins following a mastectomy, or if there's axillary lymph node involvement, kind of controversial in patients with 1 to 3 lymph nodes, but 3 or more, typically they will have radiation following a mastectomy. So in general, just really important to discuss both options with the patient if they truly are a candidate for either approach. And really, I just stress to them that there is no survival advantage to a mastectomy, that survival is equivalent between the two groups. And also really want them to know that the biology of the tumor is really what is super important here, and that, no matter which surgery is chosen, the systemic therapy is going to be very, very important. And the systemic therapy recommendations are going to be given independent of what surgery is chosen. So getting into some more details of, the types of surgery. Again, lumpectomy is the same as a partial mastectomy. Patients will see the word mastectomy on a consent sometimes and get worried, but partial mastectomy is interchangeable with lumpectomy. This is removing the tumor from the breast with some healthy tissue around it, but leaving the breast itself intact. So certainly doing a successful oncologic surgery is the most important thing, but very aware of the fact that we want to maintain the best cosmetic outcome possible also. So, and the incision placement can vary certainly depending on where the tumor is, but whenever possible, we may try to do periareolar border incisions, inframammary fold incisions, or a transaxillary incision as well. So, to perform a successful lumpectomy or a successful partial mastectomy, we want to remove the tumor with healthy breast tissue all the way around it. So I always like to explain this to patients like a hard-boiled egg. The center yellow yolk is like the tumor, and we want that to come out, but we need a nice thin layer of healthy breast tissue all the way around it, similar to the way the egg white covers the egg yolk in a hard-boiled egg. Localization techniques are used to get to the tumor and make sure we're removing the right area with good margin. These can be, image guided localization, so ultrasound or mammographic wire lokes. But this just kind of shows the importance, again, when I was talking about a clip placement at the time of a core biopsy. That clip helps guide us when it comes time for surgery and removing the tumor from the breast. So what is a clear margin? When we're talking about invasive breast cancer, no tumor on ink. So whether it's 0.1 millimeters or 10 millimeters, as long as there's no cancer at the edge, then that is considered a clear margin. For DCIS, 2 millimeter margins are preferred. So what happens if you have a positive margin? In general, the success rate for clear margins on the first attempt with the lumpectomy, nationwide, it's about 80 to 85%. So for the most part, we're going to get clear margins the first try, but occasionally there is a positive margin and re-excision can be performed. So how many re-excisions, really dependent on each individual case. Patient preference plays a role, certainly, depending on how many margins were positive. So if it was just one positive margin, very often we go back for re-excision. If like 5 out of the 6 margins were positive, we might say, hey, mastectomy may be the better option here. I've had one patient that had a lumpectomy followed by, I believe, 2 re-excisions, finally did get clear margins and was able to save her breast. Occasionally, margins cannot be cleared with lumpectomy and re-excision, so completion mastectomy is required. So moving on to lumpectomy with oncoplastic surgery. So this is basically the traditional breast cancer surgery combined with plastic surgery cosmetic techniques. Really, really nice for patients who maybe have had large breasts all their life and always wanted a reduction, or for a patient who has a really large area of cancer that needs to be removed. Maybe in the past would have been told she needed a mastectomy, but in this case, what we can do is perform a very large, wide excision lumpectomy, partial mastectomy, followed by a plastic surgeon coming in, performing a lift and reduction of both breasts to have symmetry following the procedure. So on the right here, you'll see an example of a patient who had a right breast cancer. She had the tumor removed, had a partial mastectomy, and then was able to have reduction in lift. So showed, afterwards, very nice, smaller size breast, but also had a successful cancer surgery. So moving on to locally advanced breast cancers, this is a cancer that probably is not a candidate for a lumpectomy up front, a T3, T4 tumor, or into N3 disease. These patients, may not be going straight to surgery. So these patients may not be going to surgery first. Many times neoadjuvant chemotherapy might be recommended. What we'll do is give them treatment, and then following the treatment, re-evaluate with mammogram, ultrasound to see the size. So these patients may need a mastectomy. This is removal of all of the breast tissue in quotes because we can't always remove it all. That's why there is that 2% risk of local recurrence. But going from the clavicle to the inframammary fold, sternum to the mid-axillary line, removing all of the breast tissue. A radical mastectomy was performed in the 1800s by William Halsted. This was removing the breast, the lymph nodes under the arm, as well as the chest wall muscles. Over time, we've de-escalated surgery and really found again in the 1980s that there was no survival advantage to more surgery. So from a radical mastectomy to modified radical mastectomy, this is removing the breast as well as level 1 and 2 lymph nodes, but maintaining the chest wall muscle. This is an example of a simple mastectomy without reconstruction. So nice flat here. This is helpful for fitting of a prosthesis. And really important to offer patients bras and prosthesis following a mastectomy when they do not have reconstruction. So when patients do opt for reconstruction, there's a couple different types. There's implant-based or tissue flat-based, and it can be done at the time of the mastectomy immediately or the procedure. So first an expander is placed into the area. Over time, this is expanded more and more until it gets to the size and shape ready for an implant, which is then placed. Sometimes a patient might be a candidate for a direct implant reconstruction, but it has to be an overall healthy patient who's not a smoker, small to moderate sized breast, and does not desire to be any larger when they have their reconstruction. Here's an example of a patient who had a mastectomy with implant-based reconstruction. Not all the way finished though, as nipple tattooing can be performed. Here's a patient who had a nipple-sparing mastectomy. So really nice option for patients whose tumor is more than 2 centimeters away from the base of the nipple. Smaller breasted women, we can't usually do nipple sparing mastectomies on large breasted women with ptotic breast, as the blood supply may not be significant to the nipple. Flap surgery, so variety of areas, can take a area of tissue and bring it so, the abdomen, the back, the buttocks, the thigh. But on the left here, this is an example of a lat flap. So they take tissue from the back and rotate it around underneath the skin, and it's a pedicle flap, meaning the blood supply remains intact. There are also free flaps where the blood supply is cut and they have to have microsurgery. Sometimes these are used together, so a tissue flap may be brought around to cover an implant. Really important, always want to make sure patients understand that any mastectomy surgery, reconstruction, bras and prostheses, anything to create symmetry following breast cancer surgery is covered by insurance based on the Women's Health and Cancer Rights Act. So real quickly, moving on to axillary staging, there's axillary dissection or sentinel lymph node biopsy. An axillary dissection is removal of level 1 and 2 lymph nodes. That's usually 10 or more lymph nodes. The problem with axillary dissection, although it's been the standard for years and years, it's fallen, out of fashion once we realized that the risk of lymphedema was so high. A sentinel lymph node biopsy and mapping was developed to pinpoint the lymph nodes most likely to be involved with the cancer. So it's the first lymph nodes that would encounter the cancer should it deposit. Medication is injected into the breast the morning of surgery and travels up under the arm to those most important lymph nodes to be removed. Usually 1 or 4 lymph nodes are removed in that setting. The risk of lymphedema is less than 5 to 7%. This is important for staging, and most patients who are clinically lymph node negative can have a sentinel lymph node biopsy first. Occasionally, completion axillary dissection is required, or for patients who have a locally advanced cancer, positive nodes up front, they may have the ability to downstage with neoadjuvant therapy, but following neoadjuvant treatment, the lymph node will be reevaluated. If they remain lymph node positive, axillary dissection is required. If they're clinically lymph node negative following treatment, a sentinel lymph node biopsy can be performed. So pretty straightforward. When we move on to inflammatory breast cancer, these patients get neoadjuvant chemotherapy. They do require modified radical mastectomy, and they also require chest wall radiation. Surgery and metastatic breast cancer. So many times surgery is not performed, but occasionally if someone has oligometastatic disease and has a great response to treatment, we might perform surgery in that setting. Or for someone who has widespread disease and starting to run into issues with poor response or wound issues, then we may perform a palliative mastectomy. So in conclusion, in general, very multidisciplinary approach to breast cancer treatment. Over time, we have seen that more surgery is not always better. And this has really resulted in decreased morbidity for patients, but overall improved outcomes and survival. Thank you.